Hello, everybody, and welcome to Hugh's Clues, Hypoxemic Respiratory Failure with Mechanical Ventilation, ARDS, Neuromuscular Blockade, and VAP. A big topic with lots of information. And we're going to begin with a 20-year-old college student who was found unconscious by his roommate. He's brought to the emergency department. He was intubated at the scene and mechanical ventilation was initiated on arrival to the hospital. The critical care nurse received a report from the emergency department nurse that during the process of intubation, vomitus was suctioned from this person's upper airway. This person was placed on volume ventilation in assist control mode with a rate of 10, tidal volume of 650, FiO2 of 100%, and PEEP of 5. So let's re-review the vent settings and then what would happen to this patient if he tried to take or initiate a spontaneous breath. So as we reviewed in the previous presentation, we talked about the ventilator modes, the ability or how this ventilator is responding or communicating or reacting with the patient. And in the assist control mode, the ventilator will at a minimal deliver 10 breaths at it or with a tidal volume of 650 mils. So in essence, this ventilator is just pouring in 650 mils for 10 breaths per minute. The patient can attempt to breathe, and if they initiate a breath, as soon as they start, the ventilator will sense the start of the spontaneous breath, and the ventilator will then deliver a preset volume of 650 mils. This patient in the assist control mode will always receive, whether it's machine-generated breath or whether it's patient-generated breath, a tidal volume of 650 mils. When we look at the FiO2, FiO2 is the supplemental oxygen that is being delivered to this patient. The room air or normal oxygen that you and I breathe when we're not on ventilators is 21%. And the goal for any oxygenation or for oxygenating a patient on a ventilator is to ensure that the PaO2 is greater than 60. Recall that normal is 80 to 100. So Dr. Reed has mentioned multiple times that the goal is supposed to be to ensure that the PaO2 is greater than 60. If the PaO2 ever falls less than 60, then that is a critical turn of events for a patient. So 60 is minimally maintained. And I know it seems that that's low if normal is 80 to 100, but a lot of patients in on mechanical ventilation that are very critically ill, we feel quite blessed. The healthcare team feels quite blessed when we can have it at 60. Now, notice that I've underlined this and it's bolded and in red. So this is a very important statement that Dr. Reed makes when she does her lectures. The SpO2, it's reported in the literature, really does state that the SpO2 should be at least 90%. It really shouldn't ever fall less than 90. 88% I've read somewhere that that's kind of a marker. Again, I want you to confirm these values by reading Dr. Reed's notes, listening to her lecture, or even emailing her. The additional thing that's been added to the ventilator settings is a PEEP of 5 centimeters. And after the patient has arrived on the unit, is stabilized, and has been on the ventilator for a little bit, ABGs are drawn, and here are the results in front of you. Take a moment to pause the recording and then analyze the ABGs and try and identify a possible problem. When we look at the ABGs, we can see that the pH, the CO2, and the bicarbonate all fall within the normal range. So by definition, this would be a normal ABG. However, when you look at the other two values, the PaO2 and the SpO2, we see that the patient is profoundly hypoxemic. And because they are decreased with a delivery of a supplemental oxygen of 100%, this is the definition of refractory hypoxemia. In other words, despite the fact that we have provided this patient with the highest percent of supplemental oxygen, there is still poor oxygenation in the body. So where can we go with this? If you've got the FiO2 at 100%, but the patient's not oxygenated, where do we go? What changes can we make to the ventilator setting? And what changes we expect to make are changes to the PEEP. So this is your second Hughes Clues rules. If there are oxygenation issues, you can increase either the PEEP, positive end expiratory pressure, or the FiO2, the supplemental oxygen. Now let's recall again that if there were problems with the CO2, if there was CO2 retention, then the changes to the ventilator would be with rate and or tidal volume. If there are changes with the oxygenation, then we increase, if the O2 is altered, then we will change the PEEP and the FiO2. And I know a lot of students email me and ask me, well, this just doesn't make sense to me because if we're breathing in, so our respiratory rate, doesn't that affect the oxygenation? And I would say again, yes, sure it does. But the thing that's affected first with the rate and tidal volume is the CO2. So if you want, breathe very rapidly and very deeply and do it for, I don't know, not very long, maybe 30 seconds or so, and you'll start feeling tingling in your fingertips because you now have respiratory alkalosis. You've blown too much CO2. So the CO2 is quickly or first affected by the rate and tidal volume, and then oxygen is always affected by the PEEP and the FiO2. And we're going to talk more about that as we go through this presentation. So because of the hypoxemia, we're going to have to change the ventilator settings. And because the patient is hypoxemia, the ventilator settings to change are going to be the PEEP and the FiO2. Well, we can't change the FiO2. 100% is as good as it gets. So the only other option for us is to change the PEEP. And the PEEP has been increased to 7 centimeters of water. Now let's talk about PEEP. What are the advantages? What are the disadvantages? Why is it even there? And the first thing I would say to you is that you have PEEP right now. And the reason why you have PEEP, it's again another physiologic physics things that I have to confess that I don't get. But when your glottis closes, that helps keep the alveoli open. So that's what we want. We want to keep the alveoli open. So here I have in front of you are listed the advantages and the disadvantages of PEEP. And I would just say to you that anytime there's a laundry list or what I call bullet point presentation of advantages or disadvantages, this is usually fodder or something that you're likely to see on a select all that apply. So just note that there are several advantages of PEEP, alveolar recruitment, and that means that the alveoli would stay open longer, and that means that they're more available for gas exchange. There is improved gas exchange when the alveoli remain open longer. There is decreased work of breathing and the ability to decrease the supplemental oxygen delivery, the FiO2. Now the disadvantages are decreased venous return, decreased cardiac output, and barotrauma. Let's talk about each one of those in a little bit more detail because they are so important. So when we talk about the advantages, let's recall that PEEP is positive end expiratory pressure. So with PEEP, the alveoli remain open instead of collapsing at the end of expiration. And if you take a party balloon, again, you inhale, the balloon inflates. And then if you were to express all the air out of the party balloon, which is what exhalation does, well, then you know that that balloon would completely collapse. If we had PEEP, if we could apply PEEP to that party balloon, then what we would do is allow most of the air to leave, but we would leave some in, which means that when you blow up that party balloon on the next time, on the next available inhale, then it is much easier to get air in that balloon. So in other words, when there is PEEP, when PEEP is applied physiologically to the lungs, whether it's ourselves doing it or whether the ventilator's doing it, this helps with decreasing the work of breathing on the next breath, on the next inhalation. The other advantage is that if the alveoli stay open longer, that allows more time that the oxygen can diffuse into the blood. And we do want that. We want the oxygen to jump from the alveoli into the blood. Otherwise, we're not going to have high, high normal oxygenation in our blood. And when you think about it, it's like, well, why aren't I talking about CO2? Doesn't that help the CO2? No, CO2 really does have a much easier time diffusing across the alveolar membrane than oxygen does. So it's much easier for CO2 to get out of the blood and into the alveoli and out of the body. It's much harder for the O2 as it gets into the alveoli to get into the blood. So that's just kind of another physiologic thing. I'm sure there's a physics mathematical equation why that is. I don't know it, so you don't need to know it. If oxygen can go up, we really want to be able to decrease the FI2. In other words, if you can keep the alveoli open and there is better oxygen diffusion into the blood, then the oxygenation status of the patient will be better and we can decrease that supplemental oxygen delivery. In other words, we want to get this patient off of oxygen, high levels of oxygen, as quickly as we can. Why? Because high levels of oxygen, and by high levels I mean anywhere from 50% on up. We really don't want to keep that patient on anything higher than 50% for very long. Why? Because it can cause physiologic damage to the alveoli. And again, I'm not going to go into the details on that. So we don't really want to deliver high amounts of supplemental oxygen for very long, but at the same time, we have to balance that with the fact that our patient has to have oxygen in their blood. We don't want them to be an anaerobe. Again, the goal is to ensure that the PO2 is greater than 60 and the SpO2 is greater than 90%. Well, what about the disadvantages of PEEP? Because pretty much for every advantage, whether it's medication or some kind of therapy that's delivered to the patient, there are advantages and disadvantages, and we have to weigh the risk with the benefits always. What happens with PEEP? Well, because it is positive end expiratory pressure, there is the risk that venous return will decrease. And again, this is a physiologic reason. We did talk about it in the previous presentation, but let me just go back to remind you that physiologically, when we inhale, the diaphragm drops, the rib cage pops out, and we create a negative pressure inside the thorax. And this allows us to suck in air. We are essentially creating a vacuum. Now, at the same time that air is being sucked into the lungs, this vacuum or this negative pressure that's inside the thorax will also suck up air. This is how will suck up blood. This is how venous blood can be returned to the right side of the heart against gravity. That negative intrathoracic pressure helps blood be sucked up into the right atrium, which will then go to the right ventricle, to the lungs, and so on and so on. Therefore, if we have PEEP, which is positive end expiratory pressure, we have reduced the negative pressure that is in our thorax, the intrathorax place, and we have less blood sucking power. So less blood is sucked into the right atrium, less venous return, less going to the left side, which causes a decrease in the cardiac output, and then the blood pressure can go down. Another complication or disadvantage of PEEP is barotrauma. Again, it's positive pressure. And the more positive pressure we exert or more pressure we exert on the alveoli, again, it would be like you blowing really, 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 really hard on that party balloon, and you have the potential to pop the balloon, to pop the alveoli. So let's look again at our volume ventilator settings. We have assist control, 10 breaths per minute, 650 mils tidal volume, 100% FiO2, and the PEEP has been increased to 7 centimeters, which we already identify is an increase of positive pressure to the alveoli. So it's more of a force to the alveoli as air is entering in the alveoli. So what happens if barotrauma occurs? And this is the important piece because this is all about nurse nursing assessment. What are you going to see with your patient if there has been a barotrauma situation? So the patient at the least will develop a pneumothorax. And again, because this is kind of an abstract concept, you have to realize, so if air is coming in this way and we've got a lot of pressure that's being exerted on that alveoli, if we have a lot of PEEP or more PEEP, and you might be thinking to yourself, well, wait a minute, we just increased PEEP from 5 to 7. Really? Seriously, you're going to call that more pressure? Well, exponentially it really is. Even um, small numbers really do mean a lot physiologic. So I just throw out 7 centimeters of PEEP. Some patients are on as much as 15 to 20 centimeters or whatever the measurement is, but they're on 10, 20 of PEEP. So this extra force can cause the alveoli to pop. So here is our alveoli in this area that has gone pop. That's what this gap in the lung picture looks like. And so what's happening is you have air that's collecting between the visceral, that's what these things are, these kind of reddish, purplish lines. Those are the visceral and the parietal pleura. And so when air collects in this space, you all know that that's known as a pneumothorax. And again, because this process of air collection in the pleural space takes time, 1 breath, 2 breaths, 3 breaths, 4 breaths, with each minute there's air, air, air entering this space. And as the air gathers or collects in this pleural space, then it's actually going to take up space. So you can see there's air in this piece here, and it's going to take up more and more space as it collects, and it will actually impede or restrict the lung from being allowed to expand. And again, because it is air, and we're supposed to have negative pressure in this space, and air is positive pressure, then ultimately, as more and more air is collected, the lung will then collapse because we need this negative force for the lung to stay inflated. So the lung will collapse. And then again, as more and more air collects, this gap here is meant to represent where the heart is, and all of that air that's pushing will cause a restriction on the heart's ability to fill during diastole. So now you have not only a problem with oxygenation and air issues, breathing issues, you now have a circulatory problem because this force is pushing on the heart. And when that occurs, when there's this pressure and all this tension inside the thorax, that is known as a tension pneumothorax. And a tension pneumothorax is a potentially life-threatening problem. So let's look at this on x-ray so you can kind of get a better visual image. This is, I guess technically this is the left lung. It doesn't really matter whether it's left or right. You're going to get the picture that here it is on x-ray, and you've got this air, this large amount of air that's being taking up all of this space, and then it's pushing the structures, the aorta and the heart, over to the right side of the chest. Now again, you're not going to be asked to read an x-ray. You're not going to be asked to identify these things on x-ray or diagnostically because that's what the physician's job is. But what are you going to be expected to do? Well, you're going to be expected to identify that your patient's in distress. You're going to be expected to assess your patient when there is signs and symptoms of distress, such as perhaps the patient is anxious or their spontaneous ventilation rate is more rapid, or the blood pressure's gone down, or the heart rate's gone down. So, or excuse me, gone up. So when you see some of these things, well, then you got to, and you have a suspicion, well, you got to slap that stethoscope on the chest and listen to the breath sounds. And whenever there is a pneumo, and again, here's the picture here, whenever there's air in this pleural space, the lung is collapsed, well, you're going to expect to see breath sounds that are diminished. And this usually occurs only on one side. And usually in testing situations, it's only on one side. So that's your key. That's your first key, that your patient has a pneumothorax, diminished breath sounds on one side. There is also another sign and symptom that is very important for you to remember, and that's subcutaneous emphysema. Now, subcutaneous emphysema is just what it sounds. It's air that is under the subcutaneous space, so it's under the skin. And if you've ever felt this, if you look at this, you can see these look like bubbles. Well, it feels like Rice Krispies. So we have this Rice Krispies that essentially that's air that's leaked out under the subcutaneous space, and it can kind of travel, and be as high as in the throat. So I'm going to tell you a story, not because I want you to listen to me longer, but because I've got this underlined, so perhaps it's very important to remember this. But I had a student who had a patient who was playing soccer and was rammed in the chest by another player. Of course, it hurt, and it continued to hurt through the night when the patient had gone home. And the patient was kind of thinking, well, I need to just be tough, and of course it's going to hurt. So they went to sleep, and then when they woke up the next morning and they were talking to their spouse, the spouse said, you know, your voice sounds really, really funny. And she touched his neck area, and it sounded and felt weird to her. And that was subcutaneous air that had leaked from that spontaneous pneuma from the trauma up into the neck area, of course, which could impede airway. So subcutaneous air, I want you to consider that to be a sign and symptom of a pneumothorax. A sign and symptom of a pneumothorax. What else could happen if a tension pneumo developed? As in, if we go back to this picture here, where you have so much air collected in the pleural space, the lung is collapsed, and even more air is collecting, and it's causing that pushing pressure against the structures that are midline, or that should be midline inside the chest. You can see how the trachea is pushed over, and that's known as tracheal deviation. And with this one, you can see tracheal deviation to this side of the throat. The patient's kind of turned, and it's kind of a weird looking picture. But you see tracheal deviation to the right, which means they have a left pneumo. And if you had tracheal deviation to the left, then they have a right tension pneumothorax. Now, what would you expect to see as far as your patient's vital signs? Well, again, as this tension pneumothorax develops, you've got the heart that is pushed to one side, and it's actually infringed upon, as in the heart can't expand or perform diastole, which it means it can't fill. If it can't fill as much with blood, then the heart can't pump very well, so the cardiac output goes down, the blood pressure goes down, and this patient can suffer from a cardiac arrest. So this is very important that you identify not only the signs and symptoms, what you see them, but that you understand that anytime PEEP is elevated, you really have to have diligent assessments, because these are the complications that can occur. I've also put a reference to a YouTube video for sub-Q air. I don't know that it's that great, but check it out. All right, so we've sidetracked, and we're going to go back to our patient with hypoxemia. Let's talk about the ventilator. Go back to the ventilator. So here's our setting: assist control, 10 breaths, 650 tidal volume, supplemental oxygen about 100, and PEEP of 7. And since we've changed or increased the PEEP to 7, then we wait at 20 to 30 minutes, and then we do more ABGs. And when we look at the ABGs and interpret the ABGs, we see that the oxygenation is still very high, and that the high pressure alarm keeps sounding. And also, when the nurse was listening, assessing the patient, they heard crackles. So what do all these things, when you put them together as kind of like as a puzzle, what do they all mean? So when I say the high pressure alarm keeps sounding, let's talk about that first. So whenever the patient is first put on a ventilator, The respiratory therapist will assess the patient and they'll see, well, how much force or how much effort does the ventilator have to apply to deliver the air inside the lungs? All of us have resistance. Our lungs are stretchy, but just like that party balloon, you've got to do a little bit of a push or force to get air delivered in there. And so the respiratory therapist will assess, well, how much force is needed on admission to get air into the lungs. So if you have a 20-year-old trauma patient, then because they're young and their lungs are likely very, very stretchy, then the compliance or the stretchiness of the lungs are very good, and therefore the ventilator doesn't have to use a lot of force. So, we would say that the force would be around the 20 range. And then if you had an older person or somebody with some kind of lung disease, which would cause the lungs to be less compliant or non-compliant, so less stretchy, such as a patient with COPD, then it's going to take a lot more force, we'll say 40, for the ventilator to be able to blow in air. And then once the patient's baseline is assessed by the respiratory therapist, then the alarm limit is set. Now, if at any time during the patient's ventilation that high pressure alarm keeps sounding, then that should be the clue to the nurse that the ventilator is having to exert a lot more force. So if the high pressure alarm keeps sounding and sounding and sounding, one concern that you have to consider is that perhaps the patient's lungs are becoming more resistant. Perhaps the patient's lungs are less compliant. They're less stretchy. So what does that mean to you? Well, first of all, if the ventilator alarm keeps sounding, then that means that air's not being delivered to the patient. So you have a potential problem, as in you're not ventilating your patient. But the main point is that when the high pressure alarm keeps sounding, especially with our scenario, we are concerned that the patient's lungs are less compliant and are offering more resistance. With the knowledge or what you were told before that there are crackles, crackles are the sound that um, fluid makes when you listen. So if you inhale and you hear this, then that is fluid that's in the alveoli. If you want to know what crackles are, there are sites to hear that sound. Again, you can take your hair, a long piece of hair, if you can stretch it to your ears and then rub it between your fingers, and that's the sound of crackles. So let's add up all the things that we know about this patient. The high pressure alarm keeps sounding, so our thought is that there is increased resistance or decreased lung compliance has now occurred since from the time of the initiation of the ventilator. There are crackles or fluid in the alveoli. We cannot get this patient's oxygen level up, which means despite the fact that we are delivering high levels of supplemental oxygen and we've increased the PEEP, that means the patient has refractory hypoxemia. And then the history. This is a key thing. There's a history of aspiration. So the history is very important. So therefore, the physician should suspect ARDS. Now, usually whenever there is this suspicion, and hopefully before, the physician should have ordered a chest x-ray. And as the physician reads the chest x-ray, if you hear or you see on the x-ray report that there are pulmonary infiltrates, that is a generic term meaning there's fluid in the alveoli. So you can see pulmonary infiltrates on several different illnesses such as pneumonia, heart failure. But what I'm trying to get to you is that when you have all of these things together, when you have the alarm going off indicating more resistance, less compliance, crackles, refractory hypoxemia, and a history of aspiration and pulmonary infiltrates, when you add all those things together, that really tells us that this patient has ARDS, acute respiratory distress syndrome. So what does the diagnosis indicate? Well, what does ARDS mean? So ARDS means that there has been diffuse injury to the alveolar capillary membrane. And as a result of that capillary damage, capillary pulmonary, capillary permeability increases and fluid goes from the vascular space, so water goes from the vascular space into the interstitial space and then into the alveoli. And when there is fluid in the alveolar space, then oxygen cannot diffuse across the membrane. In other words, oxygen molecules, they can't swim through that water and then jump into the blood. So that's why this patient has refractory hypoxemia, that they just simply cannot oxygenate themselves. And in addition, that water in the alveoli will damage those alveolar cells that produce surfactant, and that will actually cause physical damage to the alveoli, and that causes scar tissue to form. And so that makes the lungs less compliant, because if you look at, say you skin your knee over and over and over, that skin, that scar that's there is very different than what regular skin, and the more important thing is scarred or healed up tissue is not stretchy like regular normal tissue. So you've got really a twofold thing. You have something that has caused this leaking permeability, this increased permeability, and you have all this fluid in the alveoli, which further damages the cell and causes scar tissue to form, fibrosis of the lung tissue. So when I talked about the things that add up that equal ARDS, such as this less compliance, increased resistance, refractory hypoxemia, crackles, infiltrates on the x-ray, and then I said to you the diagnosis, there are common risk factors for ARDS. And if you look at this laundry list of problems, you can see for the most part that these are all things that really do trigger inflammation, because ARDS is an abnormal inflammatory process. In other words, something has triggered inflammation, and we like inflammation. It's a healing point for the body, but sometimes inflammation goes too far, and you learn that in patho. And that inflammation then begins to harm us, and that's what's happened with ARDS. So that's a known reason what causes it, but why certain individuals get it, it's really not known. But look at the list: sepsis, aspiration of gastric contents, pneumonia, multiple transfusions, and by multiple I mean 10, 12 units of blood that's been transfused, trauma, shock states, cardiopulmonary bypass, and near drowning. All of these things should ring a bell with you, and especially with the physician, that this patient is, or any patient with these diagnoses, are at risk for ARDS, and therefore there should be a high index of suspicion, and therefore constant assessment for this problem, for the accumulation of signs and symptoms that I have given you right here. So when you add all these things up, these are the things you look for when you know your patient has these kinds of diagnoses. All right, so this is just, again, kind of a summary, because I've been yapping a lot, that you have ARDS. It's diffuse injury to the alveolar capillary membrane, and it results in fluid that fills the alveoli, causing stiff, wet lungs and refractory hypoxemia. So this is kind of, in my mind, upside down. Here's your blood vessel that surrounds the alveoli. Inflammation occurs, and then you get leaking, damage, and then the alveoli collapse and is not available for oxygen diffusion. Moving on, so with the diagnosis of ARDS, pressure-controlled ventilation is initiated. So in other words, we've done all we can with that vent setting where we currently were, and we're not making headway with this patient. Now we need to change strategy. The physician should figure out, the current treatment of ventilator management, not working. Got to change it up. Got to mix it up. Got to do something different. And so what we need to do is, there is a concern always, because as I said, there's increased resistance and less compliance of the alveoli. And if we're just pouring in air this patient's at a great risk for having volume trauma, as in you're going to just pop that balloon very easily. So that's why pressure-controlled ventilation is initiated. So we're going to look at the differences and why we're doing that. So instead of volume, we're going to do pressure-controlled. And if you recall, I said to you, have someone blow up a party balloon while you have your hands wrapped around that party balloon. And as the balloon inflates, you're going to feel pressure against your hands. And that's what pressure-controlled ventilation does. In other words, we're going to set how much pressure we want to put on the alveoli, and this will help decrease the risk of barotrauma, of popping our balloon. But that also means because this balloon, because that alveoli with ARDS is very stiff, we are at risk for not getting enough tidal volume. So what do we have to do to get the tidal volume? Well, we're going to have to deliver a lot of rapid breaths. So in other words, if you do it mathematically and you say, okay, where we were initiating 10 breaths at 650 mils, do the math, 10 times 650, that's how much air was going in and out of the lungs in a minute, and CO2 and pH was controlled super-duper well. So we want to still achieve that volume, but we can't do it with a breath that's that big. So we're going to have to decrease the volume and therefore increase the amount of breaths that we deliver per minute. Now, how do you think this would feel to the patient? How's the patient going to react if you're making them do a hyperventilation mode, very rapid, shallow breaths? Well, it's very uncomfortable. It's physiologically against how our body works, and therefore it's very uncomfortable. And so what does the patient do? Well, the patient will fight against the ventilator. And so that presents another problem. So now you have this patient that's fighting against the ventilator pushing in air. The high pressure alarm is going to go off every second because this patient's going to be pushing out and against the ventilator. It's like two bulls just ramming their heads against each other. Essentially, where do they go? Nowhere. And that's the same with this ventilator. You're not going to be able to ventilate the patient. So what we do is the healthcare provider will likely decide to paralyze and sedate the patient. So let's talk about paralyzing a patient. The fancy word is neuromuscular blockade. Why? Because every nerve to muscular junction is paralyzed. So these individuals have complete muscle paralysis. They can't blink. They can't do anything that involves any muscle movement. And that's um, skeletal muscle movement is what I'm trying to say. So they can't do skeletal muscle movement. Obviously, their hearts can still beat. So the patient cannot attempt to breathe, and then that will allow the ventilator to take over. Neuromuscular blockades, these are the goals. It helps manage high airway pressure and improves oxygenation and allows for ventilator synchrony. In other words, when you have a synchronized skater, that means two individuals are as one. They are working together, and that's what this means. The ventilator and the patient are going to work as one. The patient won't breathe or fight against the ventilator. The group of drugs that is used for neuromuscular blockade is called vecuronium. It ends in IUM, and this is one medication, one example. Norcuron, vecuronium. There's several others that are on the market, most of them end like what you know with pharm, IUM or NIUM. Again, if a paralyzed patient can't hear, see, or think, then that means that if you're going to neuromuscular blockade a patient, then you have to give IV sedation and analgesic. Because if you don't, that means that patient will be like locked in a cell and not able to, with tape over their mouth and not able to move. So it's kind of torturous. So we don't want to do that to the patient, so we'll give neuromuscular blockade as well as a sedative. Common sedatives are propofol, Versed or midazolam, and fentanyl. the risk factors with propofol, the rapid onset, rapid metabolic elimination. This is sometimes on the exam. It hasn't been in recent years. Diprivan is that milky white medication that Michael Jackson overdosed on. Fentanyl is the medication, the opioid medication that Prince overdosed on. And you have to watch for hypotension, bradycardia, and increased triglyceride level with propofol, and the IV tubing has to be changed every 12 hours. Again, analgesia, pain control by an opioid such as fentanyl or a benzo as in midazolam. Again, here's your summary for the advantages or the actions of the neuromuscular blockade. Provides ventricular synchrony, helps manage high airway pressures, and improves oxygenation. And then the sedation and analgesia. Paralyzed patients can hear, think, and feel. So in my world, you actually give the sedation and analgesia first before you give the neuromuscular blockade. Sedation, analgesia concurrently, which just means pretty dang rapidly at the same time. So in our case scenario, these are the drugs, norcuron, propofol, and fentanyl that were delivered. And of course, every time we give a medication, we've got to assess the effectiveness of the medication. And when we do the effectiveness of the paralytic, we know that every patient responds to different dosing. And so how can we decide or how can we assess when the patient is paralyzed? So to allow for precise titration of the neuromuscular blocking agents, such as the norcuron, we do what's known as a train of 4. It's a peripheral nerve stimulator. So this is the machine here that initiates an electrical impulse. It's kind of like getting shocked. And you put the electrodes, the 2 electrodes, over a nerve. Sometimes you'll see it on the arm, sometimes you'll see it on the head because there's a nerve that goes right across the temple. And then what you'll do is you'll ask this machine to deliver 4 electrical impulses. We could say electrocution kind of thing. It's a very, very low level or energy of electricity, but you're going to deliver these 4 bursts of electricity, and you should see the nerve twitch. You should see the nerve twitch, and you count the twitches. So with every burst of electricity, you count the twitch. If the nurse counts 2 twitches out of the 4 twitches, then that is considered an acceptable range of a paralytic. If the nurse counts 3 or 4 twitches, that means the nerve is working. We don't want that nerve to work. It's supposed to be paralyzed. So that means that the neuromuscular blockade is inadequate and we need to increase the drug dosage. If the nerve counts 0 twitches, meaning the nerve didn't respond at all, the patient is over-paralyzed and you want to decrease the drug dose. Do you usually have to call the physician? No, there's like a recipe that's in the order set so that you can titrate these drugs up and down as you do it's usually ordered Q4 train of 4 assessment. If that doesn't make sense, then email me. But you've got to get your head wrapped around this. There's usually a question on this topic. Now, what about ensuring patient comfort? Well, this is very, very difficult. The patient's paralyzed. They can't communicate if there's pain. So you have to look at non-verbal cues, such as is the heart rate up, is the blood pressure up? But again, heart rate can be up for various and sundry reasons, so it's very difficult to assess. Now, at Baylor University Medical Center, and perhaps at some other hospitals throughout the region, there is this fancy machine that they use that actually will assess brain waves. And this will assess for sedation. Not all facilities have it, so you kind of just have to do your best. If there is no paralytic, we do have to assess sedation, and that's why I've popped the Ramsey scale on here. There's other scales that are out there to assess pain control. You're not going to be able to use it if this patient is paralyzed because you're not going to be able to assess whether they're comfortable or not. You're just not. They're paralyzed. Moving on kind of to a different topic now is that we've got critically ill patients. The patient's been intubated, and because of an intervention that the healthcare team has done for the benefit of the patient, we've intubated this patient. Well, there again, as in all things, there are risks and benefits that are involved with intubation. And the benefit, of course, is that, yay, the patient lives because they're actually being oxygenated and ventilated. The risk for any kind of ventilator is ventilator-associated pneumonia. And it's very important that you get and know all of these things with VAP. There's quite a bit of information in your course notes that Dr. Reed has posted, and I've copied and pasted them and put them in the hypoxemia respiratory failure worksheet, so they're there for you. But make sure you look at all of these things because this is an important topic. And why is it important to your, as a nurse, to your employer? Well, because, it follow the money trail. If patients get ventilator-associated pneumonia, then we don't get paid. The hospital doesn't get paid, and everything, therefore, has to be covered by the hospital. You don't get a raise. Now, we know the priority is let's take good care of our patients. Let's not give them problems. And because ventilator-associated pneumonia has a high morbidity and mortality, we really don't want our patient to get it. So there are nursing measures or bundles, as they're called, to prevent VAP, ventilator-associated pneumonia. So what are they? Well, they're listed here. Hand hygiene, elevate the head of the bed, teeth and tongue brushing, because our mouth is a nasty cesspool of bacteria. And so we need to not only brush the teeth and the tongue, but twice a day, we have to give chlorhexidine. There are even some places where if they're having certain surgeries, such as bypass surgery, they put chlorhexidine in the nostril because that's where MRSA lives in most of the nostrils of healthcare providers. Moisturize the lips, oral suction, subglottic suction. We're going to talk about that in just a second on the next slide. Let me just get to the last thing. This is very important. We don't do any of these things, but because respiratory therapist is involved with the respiratory status of the patient, and the nurse is really kind of involved in all things, dietary, nutritional aspect, respiratory aspect, physical therapy. It's kind of like we're somewhat a coordinator of all the health care of the patient, so we have to ensure and communicate and coordinate with the respiratory therapist that endotracheal balloon pressure remains between 20 millimeters of mercury plus or minus 5, and that there is an avoidance of routine ventilator circuit changes. Let's talk about one of the VAP measures that I mentioned, that was subglottic suctioning. And this is kind of a confusing concept because unless you've actually seen an endotracheal tube and seen this endotracheal tube that has subglottic suctioning, it kind of won't make sense. But let me try and explain it to you. So this device here, so here's your endotracheal tube. This is the balloon of the endotracheal tube. So the holes for the ET tube are down here at the bottom so that the ventilator will deliver air through the tube and out the hole, and it's supposed to go in the lung. And then this balloon, once it's inflated, will ensure that air goes down into the lung and not down and then back up and out through the mouth. So the balloon has to be inflated, as we mentioned, to that 20 millimeters of mercury plus or minus 5. And that's what this port is here. This goes to the balloon. And you could put more air or take out air through this port right here. Notice there's another port that I've circled. Not all endotracheal tubes come with this port. Again, Baylor University Medical Center has this, and some other hospitals, I'm sure, but not all places have this subglottic port. And so this port at the end is an opening where you can attach it to suction, and then this port ends right here above the balloon. So there's a hole right here that leads to this port. And so if secretions such as saliva or whatever pools right here if the patient has reflux, and so there's a little bit of vomitus that kind of slithers down the back of the throat. Yeah, I know, happy eating with that one. Then it will collect here, and then if you have this connected to suction, the thought is that it will suck that out, and so there is less of an opportunity for those secretions to slither into the lungs and cause irritation, inflammation, and ventilator-associated pneumonia. That's the purpose of this, and it is a great technology. I don't know the research on it, but you guys know what saliva is like. It's kind of slithery, slimy, and thick. So that is probably what makes it a little bit difficult to suck it out. So in theory, it should help our patient, and a lot of hospitals likely have this device to try and prevent ventilator-associated pneumonia. Now, you're not going to be asked, describe subglottic suctioning, describe what that port is. You just kind of get a sense that that's what it is. This is subglottic suctioning, and it's a maneuver that is used to prevent VAP. Exhausted, I know you are. Take a break. I've given you a YouTube link to a video that's going to help you decompress a little bit and feel energized. And then we can come back and listen to the last respiratory module, and that's the respiratory pearls. Email me if you have any questions.